This lecture will cover diagnostic imaging of the pelvis and hip. So as we look at the standard views, the hip pelvis area usually is just a standard AP image. Femur, specifically, we'll be looking at the AP image and a lateral view. There are also some other views for the hip and pelvis, such as the lateral frog leg and AP oblique for the pelvis. Judette views for the anterior and posterior views, a groin lateral view, and a Chamberlain view in single leg stance. So first we'll look at the pelvis. So the AP of the pelvis, you see the patient lying on the table. The film will be underneath the pelvis, underneath the patient. The patient can also internally or externally rotate the feet as needed to look at the femurs. And down below you see the general landmarks of the pelvis. You're going to see the upper, more proximal portions of the femurs, the hip joint, the pelvis, including the ilia, the SI, and sacrum, and usually around L4-5 of the lumbar spine. So for these, primarily we're looking at bone density, any type of femoral issues. We'll be looking at the SI joints, avulsion fractures, pelvic fractures, hip dislocations are the primary things we'll be looking at with these views. So here we see the views. You're going to see the SI joints up here. You see the lines here, the acetabulum, femoral head, the greater trochanter, lesser trochanter. You can see the obturator foramen. Here you see the pelvic inlet and outlet views. So you can get a pretty good idea of what's going on with the pelvis. You'll also see some intestinal gas through here, and usually the bladder as well. So just some more in-depth landmarks here. So you see the rami here. So you can see all the different details of the femur and the femoral neck and femoral head. You see the ilia, the SI joints, and the foramen for those spinal nerve roots as they exit out. The coccyx is usually visible here, so you can see a lot of different things here. A lot of these will be shadowed in because of the liquid in the bladder will shadow some of the lower portions of the coccyx and SI joint. The hip views, we're going to be primarily looking at the AP, and we can also use the oblique views as well. So you see all the different types of views here, and the lateral view as well. So primarily here we're going to be looking at the femoral neck inclination. So this kind of gives you an idea of the actual incline of the femur here. So usually adults are around 135, 130, 135, somewhere in there. Birth starts out at about 150. So you can definitely get the idea of how inclined this femur is. Then we look at the center edge angle, or the angle of Weiberg. This is usually about 35 degrees here. So you can see as it catches the portion of the superior acetabulum here, and then the center angle. And this angle should be about 35 degrees in most people. So if we look at the AP of just the hip here, we see the acetabulum, femoral neck, femoral head. You can be looking at all these different lines here that you see. Anterior acetabular rim, because this is a kind of a cup here. You see the posterior rim in the back. And then you can see some of the other lines, the arcuate line, the ilioischial line, and the teardrop line there that you see right here. This the teardrop line. So these all should be visible, particularly when you're looking at the integrity of the acetabulum and pelvis here. So with the AP of the hip, you're primarily looking for femoral head or neck fractures, acetabulum fractures, any type of suspected stress fracture. We'll try the radiograph first, but more likely you're going to have to go to the MRI or a bone scan to see more of the details of the stress fracture. You may see some impacted fractures here, particularly around the femoral head. Those are probably better appreciated on the MRI. You'll also be looking at these for hip OA and avascular necrosis. So once again, you see the pelvis here along with the hip, AP of the lateral hip here. We kind of went over this earlier, but you see the lesser trochanter, greater trochanter. See these lines here. So really being attentive to the femoral neck if you're suspecting avascular necrosis or a fracture. It's probably one of the more common areas here. Then we have the Ferguson, which are more oblique views. So we're going to be pushing the using a more angle of the camera here, using the x-ray beam with the film underneath, so you get more of an oblique view, so you can see more of the acetabulum here. And you're also looking for better view of the sacrum, so you can see the sacrum and coccyx here. So any type of fractures in the pelvis or and specifically the pubic ramus will be evident more on these Ferguson views. So there's the anterior. You can do an anterior internal oblique, which you're going to get more of the posterior acetabulum and a little bit of the anterior iliopubic column. So if you want to see the posterior wall of the acetabulum, use an internal oblique view. And then you can use the external oblique to get a better picture of the anterior acetabular rim. So if you're suspecting an acetabular fracture or any type of issues after particularly a hip dislocation or something like that, you would use more of these oblique views. Not commonly seen in practice except in specialty views. Primarily going to use an AP and a lateral view. Here's the lateral view, frog leg. So particularly head and neck fractures and greater and lesser trochanters are very obvious on this. So it's because of the way the legs are spread here. You have about a 10 to 15 degree angle here with the beam. You get a really good picture of this pelvis with the hip almost with the full external rotation, abduction. You see this kind of almost at a 90 degree angle, it seems, with this view. So here's the actual radiograph. So you can see all the acetabulum here. You get a really good view of the femoral head, femoral neck. Lesser trochanter, greater trochanter is going to be more up in this area. So you can see a lot different view of the femur here, particularly if you're suspecting a femoral neck fracture closer to the femoral head here. You can also do a lateral view of the groin. So if you're looking for any type of things going on with the ischial tuberosity or any type of rotation, particularly displacement of the femoral head and some of these subcapital fractures, fractures just below the head of the femur. This is probably one of the better views for this. You see it's angled at about 20 degrees from the perpendicular here, or parallel to the ischial tuberosities here. So it's about a 20 degree angle with one leg up and the film placed on the outside of the hip here. So you get this this type of view. So you can kind of look at the angle here of the femur, and you get a really good view of some of the ischial tuberosity. This is the Chamberlain view. So this is they're going to be standing on a block and letting the pelvis drop here, so you kind of get a good view for any type of instability, particularly in the pelvis if you're suspecting pubic instability here or some sort of instability in the SI joints. You can see this on the Chamberlain view. So they'll be standing, and that allows the leg to kind of drop and separate here as need if it's unstable. So that's a specialty view, not usually seen too often in most practices. So the primary ones that you'll see in practice are going to be the AP of the pelvis. You may see the AP lateral view of the hip. Those are the more common things that you will see with the orthopedic practice. So hopefully that helps your view. Look at your textbook as well for some other better pictures, and we'll move on to radiography of the knee next.